Hello, my name is Oluwabukola Adeshiro, and I will be presenting my capstone project titled Mind, Art, and Inequality: How Socioeconomic Status Shapes the Relationship Between Mental Health and Cardiovascular Disease. Cardiovascular disease or CVD is the leading cause of death both globally and in the United States. In the US, nearly 697,000 people died from heart disease in 2020, and millions were more live with some form of CVD. Beyond mortality, it contributes heavily to disability and healthcare costs. Traditional risk factors like high blood pressure, obesity, diabetes, and smoking are well known, but poor mental health is increasingly recognized as an independent contributor to cardiovascular outcomes. Poor mental health includes conditions such as depression, anxiety, stress-related disorders, and periods of psychological distress, and affects daily functioning. In the US, about 17% of adults report 14 or more poor mental health days per month, and studies consistently show that frequent poor mental health days increase the risk of developing CVD. Socioeconomic status measured by education, income, or occupation also shapes both mental health and cardiovascular outcomes. Adults with lower SES are more likely to experience poor mental health and high CVD risk. SES may also modify the strength of this relationship between mental health and heart disease through factors like access to healthcare, lifestyle behaviors, chronic stress, and biological mechanisms. Many studies have examined poor mental health and CVD, but few use self-reported poor mental health days to capture population-level cardiovascular risk. Additionally, variability in how SES is measured and in definitions of CVD outcomes leaves gaps in understanding how poor mental health interacts with SES across the population. Understanding this interaction is critical for identifying vulnerable groups and guiding targeted prevention strategies to reduce cardiovascular disease burden. The objective of this study was to examine the association between poor mental health and cardiovascular disease and to assess whether this association differs by socioeconomic status. Data from this study were obtained from the 2023 Behavioral Risk Factor Surveillance System, a nationally representative survey of U.S. adults aged 18 and older. The analysis included 433,323 participants with complete information on cardiovascular disease and mental health. Poor mental health was measured as self-reported mentally unhealthy days in the past 30 days, categorized as 0, 1 to 13, and 14 to 30 days. Cardiovascular disease was defined as a history of heart attack, coronary heart disease, or stroke. Socioeconomic status was assessed as a composite of income, education, and employment, combined into an index and categorized into low, middle, and high SES. Additional covariates included age, sex, race, ethnicity, body mass index, diabetes, and smoking status. Weighted logistic regression examined the association between poor mental health and CVD, adjusting for covariance. Interaction terms were included to assess whether the association differed by SES, with stratified analysis performed when appropriate. Over half of the participants were female, and most identified as non-Hispanic white. Participants were distributed across socioeconomic status categories, with about 12% in low SES and 44% each in middle and high SES. 55.7% reported no mental health days, 29.2% reported moderate days, and 15.1% reported poor mental health days in the past 30 days. Cardiovascular disease prevalence increased as poor mental health days increased. Significant differences were also observed across age, sex, smoking status, diabetes, and obesity, with higher prevalence of these risk factors among those reporting more poor mental health days. In the unadjusted analysis, participants with moderate poor mental health days, which is the 1 to 13 days, had lower odds of CVD compared with those reporting no mental health days, while participants with 14 to 30 days had higher odds. After adjustment for the covariant, a clear dose-response relationship emerged. Moderate poor mental health days were associated with 1.22 times higher odds of CVD, and poor mental health days, the 14 to 30 days, were associated with 1.92 times higher odds. The effect quantification between poor mental health days and socioeconomic status was statistically significant, so stratified analyses were conducted to examine the association across the SES groups. Among participants with poor mental health days, the 14 to 30 days, the odds of cardiovascular disease were 1.83 for high SES, 1.97 for middle SES, and 1.79 for the low SES group. Although the magnitude varies slightly across groups, the overall pattern is consistent. Poor mental health days are associated with higher cardiovascular disease in all socioeconomic groups. This study demonstrates that poor mental health is associated with cardiovascular disease across all socioeconomic groups, and that socioeconomic status does not fully protect against this risk. Notably, the strongest association was observed among middle SES adults. Middle SES individuals may face unique psychosocial and structural stressors, such as economic pressures without eligibility for social support, high occupational demands, and caregiving responsibilities for children or aging relatives. These chronic stressors can increase psychological distress and elevate cardiovascular risk. In addition, middle SES adults often have moderate access to healthcare, which may lead to more frequent diagnosis of both mental health conditions and cardiovascular disease, potentially contributing to the stronger observed association. Behavioral and biological pathways likely play a key role in this relationship. Poor mental health can influence lifestyle behaviors, including diet, physical activity, and smoking, while also triggering physiological responses such as inflammation, autonomic dysregulation, and other stress-related biological changes that increase cardiovascular risk. Overall, this study shows that poor mental health increases the risk of cardiovascular disease. Importantly, this risk is observed across all socioeconomic groups, meaning that socioeconomic advantage does not fully protect against the effects of psychological distress. These findings highlight the need for integrated, equity-focused interventions that combine mental health support with cardiovascular prevention, ensuring that these strategies reach all populations can help reduce the universal burden of cardiovascular disease linked to poor mental health. Thanks to Dr. Chloe and Dr. Waika for their guidance and support.